I'm Peter Schwartz. I'm the director of the IU Center for Bioethics and the Bioethics and Subject Advocacy Program of this CTSI here in Indiana, and these other titles. I have no conflicts of interest to report, but I do have special thanks to issue to some of our attendees, Amy Waltz and Beth Johnson, and other members of the IRB working group that developed the IU guidelines. I did title this talk The IU Approach, and I'm not the author of that. I'm going to say Amy Waltz really is the author of that. In some areas, I think we really have developed, actually Amy has developed a really great approach for the regulation of this. And I've been honored to be part of developing that approach and providing some of the ethics input. And this month, if you open your copy of Ethics of Human Research, Ethics and Human Research, you will see the paper which Amy wrote on returning clinically relevant research results to participants, guidelines for investigators in the IRB. That's out, I think, a couple of days ago. And we will post a version of that on our website with this talk. That has in it, I think, most of what you might get out of this talk. So here's the ethics, which I'll start with. There was an idea that there was two separate things going on called healthcare and called research, and that patients were one thing and research subjects, or as we sometimes say now, participants, were something else. The goal of the activity was different. Healthcare is to provide treatment, prevention, address disease. Research is to develop scientific and medical progress. And therefore, because of these different goals and the different people involved, the responsibility towards the individual was conceived to be different. That in healthcare, we improve and protect the health of the patient, whereas in research, we minimize and avoid harm to the participant. The goal being not to take care of them, but to advance science while being respectful to them. The reason for the individual to participate in the activity, patient, is to improve and protect their health. It's very self-oriented. The idea is to offer them services that are valuable. The research participant, the idea is they're there to benefit future patients. It's an other-oriented activity. There's an altruistic component. Yes, there are sometimes goals that the individual may have participating in research. They get paid. And in another Treats talk, I've spoken about the debate about how much to pay research participants. They also may be receiving treatment as part of their research participation. But in general, the idea is these are two different activities with different goals and different stances towards the individual participant. Now, we do get results, though. So in research, we get primary results, the ones we're actually after, and then secondary and incidental results. So other things that turn up. By the way, in honor of Karen, who's here in the conference room with other members of our center, I should point out that actually returning results there's an ambiguity to it. When you do research and you do make advances, maybe through the primary findings that you've achieved, and when you've got aggregate results, perhaps you've confirmed the hypothesis or you've disproven the null hypothesis, that is information that participants in research might be very interested in, and which has generally, I'm going to say historically, not been returned. And I think there's a bit of a revolution going on there too. For the grants that I do, largely funded through PCORI, we're actually required, we promise anyway, to return results to our participants. That's aggregate results. In the case of what we're going to talk about today, though, we're going to talk about individually relevant results. So things you might find in the process of doing the research, which actually can impact the health or future health of the patient. So the examples, the classic one would be the BRCA gene, which confers high risk in some cases for breast cancer, ovarian cancer, other cancers. Perhaps an X-ray that was done as part of the research project that shows a brain tumor. A lab test that was done as part of some safety monitoring or part of the research, which shows a potassium of 7, which is a life-threatening number. Or when we do a PHQ-9, which is a score having to do with depression, perhaps we identify a patient who's suicidal. All of these are things that are actually have important implications for the health of, here I used the word patient, I sort of couldn't help myself, of the participant. And we have found it as part of research, but now we don't know quite what to do. We've got important information. The idea was that we would not be giving results back, again, historically, traditionally, but suddenly we have something that seems important and an ethical question. Again, traditional view is don't return results. Possibly for a life-threatening thing like a potassium of 7, that, I think even traditionally, the idea was you would certainly tell somebody to save somebody's life. But we also included in informed consents very explicit statements that this is not healthcare, you shouldn't come here for results, and therefore you won't be receiving them. The changes, there have been changes, I'm going to say in the last 15, 20 years. People have pointed out that withholding information, even though it's a non-action of not giving, perhaps withholding information is a kind of harm. You're harming the person who very nicely and altruistically perhaps participated in the research project. And we do have this idea in ethics of a duty of rescue, that even if you have somebody who you have no obligation to, you're running for exercise and you see a child about to walk in the street, you don't have any obligation to that child. It's not your child. He's not somebody you're providing care to. But most people, most reasonable people would say, oh my God, you have a chance to take a toddler and grab him and move him away from the street. You should do that. It's basically something which has great benefit to the individual, minimal risk to you. You'd be some kind of moral monster, not to put too fine a point on it, to jog on and not help just because you want your exercise. Second thing that's happened is this idea that the line between healthcare and research is being blurred. So there's research, of course, that involves clinical care, like clinical trials, and there's healthcare that serves as the basis for research, where we look at the electronic health record and go back and do research based on care. And so the sharp line that in healthcare, we're providing care to patients, in research, we are not providing care, we're just developing generalizable knowledge. Again, once this line blurs, that line in how we treat important results also becomes less convincing. We've had a changing view of the research participant over time, from the idea of a subject to being a participant. We now actually sometimes use the word partner for the participants. We are much more aware of the importance of community involvement in our research, both in terms of overseeing our research, perhaps proposing our research, and also, as I mentioned before, we pay better, and I think we're moving towards a better understanding of that. When we get genetic results, the American College of Medical Genetics and Genomics issued in 2013, it was a smaller list then, but they issued a list, it's now 81 genes, that basically when you go in for genetic sequencing clinically, the ACMG says that basically you should return and test for these 81 genes because they are so important. This is, of course, in the clinical care, not for research. The idea is that it's independent of the reason for testing. Patients can opt out, but it should be considered sort of a standard. Now, how do we apply this in the research setting? Do we also have to test 81 genes and return them? Geisinger has a group, had focus groups in their community and decided as part of their biobank that when participants came in to donate blood to their biobank, I think in the case of Geisinger, it was leftover clinical samples, they would sequence it for the 77 genes, I think it was 77 they settled on, and any positive result would be given back to the participant. They broke the line, right? They're saying, no, we understand it's research, but when you come in to participate in this research project, we will sequence your genome, and when one of these genes shows up, we will tell you, and we will disclose this to you in the informed consent. So Geisinger is a good example of blurring that line. When the common rule, which governs the regulation of research, this is again Amy Waltz and Beth Johnson's expertise more than mine. But when the new common rule came out for oversight of research, we have this important sentence that was added, saying that informed consent should include a statement regarding whether clinically relevant research results, including individual research results, will be disclosed to subjects, and if so, under what conditions. So now the regulations have caught up with some of the ethical concerns that, maybe we should be addressing this in the informed consent. But this is all the guidance provided. Just that participants should be told whether they're going to be results back and under what conditions. So how will we do that? And so the rest of this talk is going to give you a quick guidance on how I've always thought about this ethically and the way that the IU-IRB thought about it as we updated the regulations. The first step, again, in this initial introduction, I'm happy to have further conversation, the question and answer, or in other settings. But the first step is to separate the types of individual research findings into bins, as they've been called. The first ones are the ones that are significant for the person's health in the near future potentially involving risk of death or severe morbidity, and where there are interventions available to improve outcomes. Second would be ones that are similarly significant, similarly actionable, but where there's a little more time. It's not immediate. A potassium of 7 can kill you today. A BRCA gene can put you at risk for something down the road. So maybe that would be one way to think about these first two categories. A third category would be something which is significant for a person's health, but where there are no interventions available that improve outcomes. Something like a gene that might put you at risk for certain disease in the future, but where we have no approved preventive measures. So it's interesting. It appears to be important, but it's not like 1 or 2 because there's no action indicated. A fourth category would be things with unclear significance. So ones where there are some gene, we don't really know what it means. Maybe there's some thoughts about it. Not only are there no interventions available, but we don't quite know what it means. And if you separate these 4 categories and you run them down the side there, then you can see that things have shifted as you change category. First of all, the benefits shift from very high in 1 and 2 to questionable or non-existent in 3 and 4. The risks of disclosure are present for any of them, of course, but perhaps more so in ones where we don't know quite what a person might do. Misuse, anxiety is always possible. And as you go down the list, you have decreasing benefits and perhaps increasing possibility of misuse or misunderstanding. The famous case, I believe it's apocryphal because I have not been able to confirm it, is somebody who was told, well, there's a gene that we have found. I don't know if it's a clinical or research setting, but it's a great example that shows that you might have increased risk for gastric cancer. Please don't act on this. It's not important. It's something we'll have to look into later. We can always talk about it later. And the person went and found a way to get her stomach removed, found a surgeon who would do that. And again, later research showed that it was not a useful gene. So that's the kind of story that gives us pause about giving back results in that 3 and perhaps 4 category. Of course, it's a scare tactic to mention that story. I can't give you a citation to it. Maybe Colin can. I think Colin's been looking it up. So here's the bottom line. Here you go. We're just 15 minutes in. I'm going to give you the answer. And the answer, one answer, a good answer, and the answer that IU has put into place in some ways, although we leave it to researchers to make some choices, is that when you're in the first bin, that really should be disclosed. Even though it's research, even though the person didn't come for care, if it's significant and something that may have an impact very soon, and there's steps to be taken to protect the participant, then it should be disclosed to the participant or the provider in a way that's effective. If it's significant and actionable, but there's more time, things are a little less direct here. There's still a sense that perhaps this should be done. There's a push towards it, although not like in the first category. In the third category, it's interesting. It appears to be informational, but there's no clear intervention. This is a case where we really don't know, and researchers are going to have to choose what they want to do. And finally, when you're in the fourth category, there's a lot to be said for not disclosing unsure results. Again, not a must, not an absolutely not, but there's more and more concern as you go down this list. Here's some caveats and considerations. First, disclosing things requires resources and expertise that may or may not be present on the research team, and that should be taken into account as well. When we sequence genomes as part of clinical care, the ACMG recommends a duty to hunt, you might call it, that you should be checking for those 81 genes and returning them. In the research setting, generally we believe that there's no duty to hunt like that. There's no need to go and look for things just because there's an opportunity. If they're found as part of the research project, then you really should act on them, especially in bin 1 and probably in bin 1 and 2. But there's no requirement to go down and look for all genes or do that kind of clinical sequencing to look for the 81 recommended genes because it's clinical, because it's research. Again, I'm happy to engage that topic. Perhaps some people on this call even feel that there should be some sort of duty to hunt. Certainly, returning results could be part of the inducement to participation with all the caveats to that. it might be a good thing to offer people. On the other hand, if you're offering things that don't have actionable or clear meaning, then you might think about the potential harms. Again, we recommend considering benefits and risks of disclosure. There should be, of course, part of consent in keeping with the common rule that we should explain the system for returning results. There should be a plan for how to return results. It should be who will do it, how they'll do it, how to think about follow-up care. We can return results that are not checked in a CLIA lab. So that's a lab which meets the requirements for a lab testing. That's a fact that is still present for the regulations. There's some questions about what could be said, perhaps something like, well, we have a result which we recommend you look into. We can't, tell you this result is for sure. There are different opinions in the regulatory world. Actually, maybe Amy can update me if she knows on whether that statement is okay. Here at IU, I will say, maybe I'm speaking out of turn, but at IU, the idea of at least saying, look, we found this result. It's not a clinical lab. It's part of our research lab. We recommend you go and get clinical testing. Whether or not it's officially okay on a national level, I believe IU has stood behind that disclosure and felt that the risks and the potential harms of refusing to say anything just because it was not a CLIA lab is probably too high, and recommending that a participant go and get follow-up testing is probably the right way to go on an ethical front. We talked about the danger of returning results that are not clinically valued. And in the similar setting, the two areas we really think about incidental results perhaps most actively is in the genetic realm and the radiology realm. And you could say, well, GP, you say you want to tell patients if you happen to notice a tumor on an X-ray done for a clinical trial. Well, maybe then that means you must have a licensed radiologist look at every scan. And once again, that is not a recommendation. The finding of results, there is no duty to hunt. We are standing by the idea that you've come to get an X-ray as part of your as part of your research participation. You should not expect that a radiologist will examine that X-ray and give you a read on it. That was not the agreement if you're there to do research. It's just that if it is noticed by the research practices, then probably a tumor or something questionable should be mentioned. This is an interesting question. If you have results that are being analyzed in a secondary analysis, perhaps later, is there any of the same responsibility, perhaps of looking for bin 1 or bin 2 and returning those? And in the writing so far, the ethicists have recommended that there not be considered to be a responsibility at that point when time has passed. This would certainly apply to the biobank setting, where perhaps research is being done years in the future. Here, I'm giving you the short introduction. As I'm speaking, I'm realizing how many wonderful open questions there are, how much more needs to be done. Bottom line is to anticipate results that might be relevant to your participants' health or desired by them. Decide about whether you'll return those results, taking into consideration the categories, the benefits and risks of returns, and the expense and resources needed for the process of return. And that plan should be disclosed during informed consent to allow participants to decide what they want to get back. I put IRB role here because actually one of the brilliant parts of the IU approach is that now that it's part of the common rule to ask researchers to disclose to participants whether they'll be getting results back and to give them a choice about it. You might think the IRB has to delve in very deeply into these plans and evaluate them for participant safety. On the one hand, that sounds reasonable. On the other hand, the IRB has much to do, and a great danger of adding requirements to investigators, adding issues that must be reviewed, is that IRBs become overwhelmed. There's a mission creep. And I use IRB, I think, made the very wise decision as part of this update. I'm calling it the IU approach, to require that that researchers come up with a plan and that they include in consent the required disclosure to participants. But that they, as an IRB, would not be examining that plan at some granular level, such as going through each possible result and deciding whether the decision that the researcher made was in keeping with the recommendations. And I stand by that decision. I think it's a wise use of IRB resources to put the burden on the researcher to make it clear, as perhaps maybe some researcher will learn from this Treats talk or from the materials provided by the IRB, what they should do, what they might do, to guide them in what they should think about as they make that decision, and then to stand back and let them lead. I think that's a wise choice, and I think it's a lovely part of what you might call the IU approach. And again, it's described in that paper I mentioned at the beginning, which will be posted with this talk later. I did include this table. I'm not going to go through it. This is a table from the paper that Amy and Beth put together. It's the IRB information, again, with the bins, with the result level. This is bin 1, what we recommend that the researcher does, and some model language for the informed consent. And this table, which I broke up here just so it'd be readable on the slide, is this is bin 1, this is bin 2. Sorry, I don't want to upset everybody by going too fast. This is bin 3, and this is bin 4. And so that is meant to make it clear to the participants, to the researchers, what they might think about as they go through it and what they might disclose with, again, model language that they might use. I have resources here, links to the 2 main national guidelines that we used in developing the IU IRB guidelines, as well as these are wonderful resources for ethicists. And I do need to mention that you can always come and get input from the Bioethics and Subject Advocacy Program of the Indiana CTSI to talk through these issues and help guide you in making choices. Our contact information is here. So I've closed that, and now if I'm smart enough, I'll figure out how to stop sharing my screen. There we go. And I'm happy to have a discussion about any of those many fascinating and questionable claims I made. I sit here with some fear and trembling for all the great questions this illustrious group might raise.
Peter,
Anna Marie.
Big surprise that I'm asking questions.
Love it.
So couple of things, one of which you covered. So basically, if I am doing genomics in a non-sequencing, in a non-CLIA lab, and we, as one of the mutations, come up with an action, what we would in genetics call an actionable mutation, your recommendations are that we should inform the participant. Now, when the person assigned to this informs the participant, does he or she say you have a BRCA1 mutation on this testing, but it's research testing, or do we do the ridiculous that's going to actually increase anxiety a millionfold? We found something we're really worried about on testing, and we really think you need to have genetic testing in a formal genetics lab. Where do you stand on that?
Yeah, well, so I have an opinion, and I'm not sure I can fully defend it. I'm going to go ahead. And so I agree with you that the second way of saying it is horrendous. And the first way of saying it seems much more reasonable. Say, hey, look, we do not do CLIA testing on our samples. So we don't, this is not like having your doctor run a test. But on the testing we did, something showed up, which indicates you may very well have a BRCA1 mutation, which carries these kind of risks. You need to get clinical testing. This does not, you cannot act on this result. Go to your doctor, explain what's happened, and get normal clinical testing. Now, my reluctance to say that out loud, which I just did, is that there was a specific ruling from CMS saying that what I just said is against the rules.
I got it.
If it's not CLIA testing, you can't say it. You can't say, I have non-CLIA testing. This actually has come up at IU, and I have great respect for the legal office. If somebody can, if Beth's here, Beth has moved over to the legal office, she can tell me to stop talking and give me a cease and desist order right now. But I believe IU has said, look, we understand that's the guidance, but what are you going to do? You can't say the second thing Anna Maria said. There's just something you should go look for. We can't tell you what it is. Come back and tell us what you find later, and we'll tell you whether you found what we were worried about. That's obviously not a good way to treat people. So if you're going to disclose anything, and perhaps you said in the consent that you would disclose certain kinds of funding. By the way, there are researchers on campus who have made the extra step of drawing a second tube, and when they have something like a BRCA, they have a tube to send for CLIA testing. Now, that's an expense in the trial. It requires forethought. It avoids the problem. And given now we're anticipating the problem, perhaps it deserves forethought and anticipation. But you're right, Anna Maria, Dr. Sterniola, if you find yourself in the position you described, I believe the right thing to do ethically is to say what you first said. We have found something. You can't rely on this. You can't get treatment based on this. You must go and ask for genetic testing from your providers or your healthcare system. Amy, I'm giving Amy the right to step in here and tell me I got this wrong, or yeah, she's giving me a thumbs up. That's why she's here. So when I lose
I have one other question, and then I'll shut up for a while. So my other question is kind of, is there something to do can be interpreted multiple ways? And I'll give you a very concrete example. So if I do a breast biopsy for the Komen Tissue Bank, and I see atypical hyperplasia on the slide. Now, the slide is not, there are issues here because it's a blind biopsy. So we don't know exactly where the biopsy was from. Now, but we also know that atypical hyperplasia, though not a malignancy and not a pre-malignancy, is a biomarker of risk and can increase your risk, some people say up to 4 to 6 times. Now, the only thing that we would do by guidelines is offer that person a course of preventive tamoxifen, but it's preventive. And it's preventive in 50% of people who you do that for. So you're in the situation where you didn't know where the biopsy came from, except for which breast. You have a marker of risk, but but tamoxifen is only so good.
Yeah.
And so thank God this has not happened yet, but do we call them and say, you need to see a risk counselor about this?
Good. Next question. Nick, can you please silence Anna Maria's microphone? No, it's a great question, Dr. Sterniola. It's a great question. And I guess what I'd say is you anticipated, you haven't seen it. I don't have a clear answer for you. This is part of why I think the IRB was wise to say, Anna Maria is a world expert on this question. She needs to think about what she will tell people who donate to the Komen Tissue Bank. Are they, if it may be important for you to say to them, look, if I find cancer on the biopsy, I will tell you. But if I find a pre-cancerous condition, which has unclear, did I lose you? Oh, no, there you are. People's faces are jumping around. Which has unclear implications, in fact, complex implications, where preventive treatment would not actually be, you're saying, again, you're out of my realm on whether it's indicated. I guess it's a situation where the biopsy wouldn't have occurred at all clinically unless there was an abnormality on mammogram or something, or maybe this person who's young. I guess your point, you might say, look, what I can tell you based on the biopsy, short of a cancer, short of DCIS, I will not tell you other things we find. I might recommend that you go through a formal clinical risk evaluation, but that's all. And in that situation, you are treating them differently than a patient, right? A patient who had a biopsy that you're describing, I'm sure you would probably be prescribing tamoxifen. But it's okay to see participants different and to be clear ahead of time that they are not coming for care. They're not coming for a clinically indicated biopsy to look for risk stratification, and therefore you will not go down that road. You're in the bin 2 or bin 3 realm, and you're like, look, I'm therefore going to decide ahead of time, as the IUIRB recommends, that I be clear with you that I'm not going to do that. It's not like, again, to go back to the first silly case, right? Silly but heartbreaking case of a child wandering out in the road. You're not in that situation, right? You're in a person where there's some risk, you sort of feel like you should help, but you're in a research setting and that's not what they signed up for. And you're not going to try to take on the role of the clinician. I can read Colin's mind that he is happy that I said that. Because up till now, I was like, go, 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 give those results back. But Colin's going to tell you, and it's a conversation we have in our ethics centers, why I'm picking on Colin, about different takes on this exact hard question you're asking, Anna Maria, which is, what do we do when we get some indication we have a person in front of us, we want to become their doctor? We want to become a provider to them. And I'm saying the second case you provided, my feeling is don't become their doctor, leave their clinical care alone. Whereas in the first case, I wanted you to step in and actually step over beyond the regulatory guidelines to give information that you've collected. But that's my take. The IUIRB, and I think a good ethicist would tell you, take your take and decide what your resources are and where your comfort level is. How's that for a non-answer, Anna Maria? It's a good one. Okay. Colin's got his hand up, so he goes next because I picked on him.
Well, I was happy to hear. I didn't realize that we were rewriting these guidelines, so I'm happy to hear that's where you guys landed, because it is that's my feeling on it too. That these are distinct spaces, but the thing that I wanted to add is in constructing your project and constructing your protocol, it is something to take into account not just the patient's needs, but also the team's needs. And understanding that if you're not going to return the results, if you feel like you're under-resourced to provide education or access or follow-up or whatever, or you think that the participants won't have the resources to pursue the appropriate next steps and you can't provide them with your grant funding, it's important at the outset to think that do you want to be returning any results? What types of results do you want to be generating if you can't return them? When I was in my postdoc, I wrote an article, I think that was in Genetics and Medicine, where we talked about what we called the clinical impulse, which is this kind of moral distress that researchers face when they wear both hats of being someone with either a clinical relationship with the participants additionally, or at the very least having kind of a clinical background that would allow them to have this type of understanding of the potential harms that the patients could experience or the participants could experience by not having that information. And so not just I think it's important, not just what's in the patient's moral best interest, but also in what's the research team's moral best interest as well.
I love it.
It's interesting. Thank you, Colin. It's interesting because as I was thinking about this and getting it out of the breast cancer thing, you could make exactly the same clinical and guideline argument for a high cholesterol. If somebody comes in and you're doing non-CLIA testing for whatever, and you get a cholesterol of 260, am I going to call every one of those patients and participants and say, your cholesterol is too high, you need to be on, because there are guidelines for what to do with that cholesterol. But again, it's what you're recommending is a preventative approach. And so this gives me some comfort. It makes a lot of sense. Thank you.
Yeah. More questions, please. We could go on this topic. And I like that you raised the cholesterol example, Dr. Cerniola. Again, in keeping with the common rule, maybe explaining whether they will get cholesterol testing as part of their participation in the trial, in which case maybe CLIA testing would be appropriate, since that's available and probably not too pricey. And maybe that is something that you want to offer participants as an inducement, that they'll get their cholesterol checked and they'll be sent their results and they can take them to their doctor, right? So you're sort of proactively thinking of the things you're going to be testing or might test, and trying to create a situation where you are, disclosing to the participants what's going to happen and being aware that there may be opportunities to help their health, but also that it's a different situation than than clinical care. And Colin is putting, oh, thank you, Amy, for the guidelines in the chat. And it is actually real. So Colin, you're confirming this is a real case. You spoke to the woman. Outstanding and heartbreaking that this happened. Other questions?
I have a question, Peter. Dr. Schwartz.
I called Anna Maria like 10 times. And I called Colin.
We're good. We're good.
So I'm Peter. I'm just telling Nick to call me Anna Maria. Nick, call me Anna Maria. I mean, call me Peter.
Peter, earlier you were talking about the duty to hunt, and I was curious if it could be an option for participants, if their samples are available to be tested, that they could opt in or opt out, and that could be an option for participating, and potentially even a form of compensation or inducement, as you mentioned earlier.
Yeah, no, the short answer is yes. I think it is yes. And I think the IUIRB's guidelines and the opinion of this ethics group are that if you wish to return results as part of the inducement to participate, then that's fine. You should be aware of the 4 bins. Think about whether you're offering something which you won't be able to explain. Like maybe if you're in the 4th bin, you've got a variant of unknown significance, and you think people will love that, and I'd like to return that to get them to participate. Well, that could have ethical problems, right? Because you're taking advantage of a misunderstanding, and you're not providing the context for the result that you're providing. And now you should think, I think as a research team, a bit about whether that's the road you want to do. Now, can you offer to do the 81 ACMG recommended bin 1 genetic testing? Wow. Well, maybe that is a good idea, right? Those are already been identified as important genes with actionable results. And if you can offer that, and maybe even better if you're going to offer it as inducement, of course, CLIA test it, right? So you don't get in the situation Dr. Storniola raised of having non-CLIA results. Maybe that is something where you should actually think about that as a resource that you need to commit to getting that testing done as part of the inducement to participate. Now, that's not a duty to hunt, Nick, I'm going to say, because duty to hunt would be, I'm just to reiterate for people on this call, is that in the clinical setting, when you're doing genetic sequencing, ACMG recommends a duty to hunt. You know, you should check those 81 genes and return them. You're doing sequencing for clinical reasons. Maybe you have no interest in checking those 81. Because you're sequencing, your report should include a report on those 81 genes and giving the patient back the information about any pathological variants. There's an opt-out. There was a big debate over whether it should be an opt-out, but there's sort of an opt-out now, but it should be a standard. Within within research, that duty to hunt is just not being accepted. And I would argue against a duty to hunt, that if there's no reason, if you're doing some kind of sequencing of the genome or some testing of the genome for research, there's no reason to go looking for those 81, unless what you said, Nick, unless you decide that is something you want to offer, maybe as an inducement to participate. And if you do, then certainly you want to think about the system for returning the results, the context, and the explanations. Emily Nelson is not responding to what I just said. She's on camera. She's only having. She screamed and happily and ran to her door. So I'm glad to see that. I don't think it was what I said. And she also took off her earphones, so she doesn't know I'm talking about her. Sorry. Other questions? I got distracted. Sorry, Emily. Okay.
So I have another one, which is a regulatory question.
Maybe.
So how deeply do we go in writing our consent form? How far into the bins do we go? Do we just mention what we are or are not going to do with generic language about bin 1 and bin 2, or are we going to go all the way down to bin 4? Don't laugh at me.
Oh, I'm not laughing. I'm actually smiling because Amy has come on camera, which means I can be quiet.
Yeah. I don't think you need to say what you're not going to provide. I think the regulation says if you are going to provide clinical results, you have to say so. Is that right, Peter?
Actually, I'm going back to that slide. Good
Okay, yeah, go
question.
back to that slide. But I don't think you need to say we're not going to provide these, things in these categories. I think you can just say, if we find something that we believe is critical to your health, we'll share that. And then also anything else that you've decided. So I think that's kind of up to you. I don't think we need to get super detailed about this. The important thing, again, as always, is not to get the participant caught up in the details, but to give them a good expectation, a good understanding for what to expect. So a statement, whether results will be disclosed, and if so, under what conditions. So I just looks like it's even more vague than what we were even going for. So, I think it's up to you and the IRB. But ultimately, I don't think you need to get into specific details about what you're not going to share.
But here's something else we're not going to share. Have you ever heard of variants of unknown significance? Let me tell you what those are. We're not giving those to you.
Right.
But it is a matter, as usual, in this sort of things, where there are a lot of judgment calls. And I think one of the great insights in this set of recommendations at IU was that we're going to leave that to the researcher. So Anna Maria, if you are committed to explaining the 4 bins and why you will not be receiving back, things from bin 4 and what that is, well, I hope the IRB is not going to spend time sort of double checking what you've done there and, saying, well, no, you've explained too much here. Let's cut this back. Because again, the IRB has already a mountain of work. And as we all know as researchers, one of the greatest harms to participants and to the progress of research is an overloaded IRB trying to do things that's outside of their expertise range. Whereas you, Anna Maria, you have expertise in this area, which the IRB is going to require you to have a statement as required by the common rule. And it's going to expect you to include an explanation just like the guidelines said. But beyond that, they're going to take a hands-off approach. You say, how can you take a hands-off approach? What if they're saying they're not giving back that breast, the atypical hyperplasia result? The IRB should get involved in that. IRB says, we're not getting involved in that. That's not the sort of thing that IRBs should be doing. And actually, I think that's in some ways the most interesting part of these guidelines from IU. The bin thing's been around for a long time, but I find it very interesting and actually ethically complex and important to talk about the limits of review, just because it's about efficiency and effectiveness of research. And there's a hand up. Somebody had a hand up. Did I miss it? I thought somebody had a hand up.
Sorry, that was me. I did have my hand up.
And
it was interesting because I was going to ask how you handle the variations of unknown significance, and then you essentially joked on it, saying that you wouldn't. Yeah.
I mean, you could give it back. I mean, I think Amy Waltz and the IRB is not going to stop you if you say, you know what, as part of this research, we want to give back. Let's say it was, I'll even the full sequence. Like when you come in, and this is part of Nick's question, right? Part of the payoff of participating in the Nick Oliver genetic study is we will give you a DVD with your sequence on it for you to use as you wish. You can go online and look things up. Now, I think that might be unwise, but I don't think it's unethical. And with the proper disclosure and perhaps some idea of how to send people in the right direction towards doing things, I guess I'm going to say, let's let 1,000 flowers bloom. It may be that some of these flowers don't smell very good, but I think we need to sort of allow researchers to approach these things as they wish. And Colin is on camera, which means I have stepped over the line.
Wait a minute. I do have a huge objection to that. So revealing variants of unclear significance means or assumes that that presumably the patient at this point is going to go talk to their doctor, presumes their doctor understands what that is. And I have personally seen people with variants of unclear significance in BRCA1 or BRCA2 genes who saw me, thank God, before they were already on the operating schedule to have bilateral mastectomies because their doctor assumed that was bad. So
yeah. No, your concerns are fair. I'm going to leave this open because Colin's going to jump and he's going to pile on. Now that you've got me down, Anna, Colin's going to kick me while I'm down. Go ahead.
I just want to kind of reiterate what Dr. Storniolo said. I also think that this is a problem. I do agree that fundamentally there is probably there are limited issues per se with returning even all results, but the problems arise with the potential harms, because even in clinical settings, the explanation of a VUS, of a variant of uncertain significance, to a patient is very challenging. And so again, the amount of labor and person hours that would take to disclose that information in a way that isn't harmful, like with appropriate education, appropriate referrals, that kind of a thing, is even more challenging under research settings, research conditions. So I would just, I'd be very hesitant to promote the return of a VUS through research.
And sorry, I'll get you a second there, but I like what you guys are saying, and I do believe you came to the BSAP program with questions. I think you would get this kind of advice from Colin or me too, saying maybe not a good road. Maybe instead of giving them results back like this, you know, you're almost taking advantage of a lack of understanding of the usefulness of these results. Why don't you give them $100 instead, right? Instead of doing that. In fact, this has come up. There was a study that wanted to give people, since they didn't want to give back genetic results from their own study that will remain nameless, as I always treat all your consultations confidentially as well. They wanted to give them a free Ancestry.com subscription. Said, well, let's not give them results, but let them go to Ancestry.com. And part of the ethics conversation around that was, interesting, do you wish to endorse that as a useful way to spend their money? Or would you rather just give them $50 and they can decide if they want to spend it on Ancestry.com? And I think we went with the latter. That even giving an Ancestry.com is almost to endorse and encourage a certain kind of, you know, use of genetic testing, or, you know, direct-to-consumer testing, but such as it is. And I think that team decided, oh, actually, maybe not. But again, I think the IRB would have let them if they had wanted to. I think we're not talking about, you know, such a harm that the IRB should be stepping in saying, we reviewed this, we sent this to genetic, you know, counselors, we decided this was really a bad idea. I think we're going to let researchers decide, and hopefully with some guidance from people like me and Colin and others and Amy to do that. Surya, I'm sorry, I didn't let you go.
Oh, sorry, I just had a follow-up on that. Just a comment, actually. So in Australia, in the obstetrics world, when you do like an amniocentesis, we often get like these VUS, the variations of unknown significance, and it's like always quite a common clinical conundrum as to how to counsel the patient. But one thing that I was quite curious about was, you know, the value of providing the patient with that result, so that in 20 years' time, when our research has advanced and we have more data in the bank, maybe that VU will actually translate into some type of clinical pathology or not. So there's obviously pros and cons both ways.
Yeah. And is it the researcher's responsibility to remain in some lifelong, or maybe even generations, right, long conversation with that participant to update them on developing understanding of the genetics they were found? Hopefully not. That seems like a bridge too far for the responsibility of a researcher and perhaps even a clinician. So again, these are open questions for the use of genetics and the developing world. Some of the things that ethicists and some people at our center like Colin are working on very closely. So any other questions? What a wonderful discussion. Again, thanks to our discussants, our unofficial discussants who stepped forward. I think we really have covered some great topics, and I've gotten across the message I was trying to send, I hope. Again, the nice thing is to know that you can get help either from the IRB or from the bioethics program with the CTSI, or just write to me or Nick. The slides will be on our website soon, along with the recording of this discussion. So thanks all.
Could you put the reference that you initially, the paper that just recently came out, could you send us that reference again?
Absolutely. Like I said, we're just going to put it on our website, Anna Maria. I'll send it to you personally this afternoon
Great.
before we speak. Again, I'm very proud of Amy and Beth for putting that together and getting it into print along with me. And I can send you that, and we'll have a link to it on the website. Thanks, Anna Maria.
Thank you.